as you all are aware of what HHT is, the history of HHT, but I would like to focus only on one of the many manifestations of HHT, and this is the brain AVMs. And we will talk a little bit about the different types of brain AVMs, when they occur, what their symptoms are, and also what their treatment possibilities are nowadays. We all know that the most common presentation and of HHT is epistaxis, and at least for my practice, most of the HHT patients that I treat for epistaxis, where we see on this injection with contrast material. These are the arteries that go to the nose, that there is too much of a blush within the nose that is related to these telangiectasias. Epistaxis in HHT is very uncommon in the pediatric age group. It increases with age, and unfortunately, the response to endovascular treatment only holds up for approximately 1 year, and then repeat embolizations have to be performed. Let's talk briefly now about the neurological presentations of patients with HHT. They can present with stroke symptoms, and these are often due to paradoxical emboli of pulmonary AVFs. And this is due to the fact that pulmonary fistulas, arteriovenous shunts, are way more common than the brain AVMs. The vascular malformations itself are relatively rare. In fact, when we look at the numbers, it is for every 10 abnormalities within, let's say, the lungs or in the GI tract, we have maybe 1 brain AVM. So it's a rare disease in HHT. In order to understand HHT, we'll have to understand a little bit the pathophysiology of those genes that are defective in HHT. And the major point that I want to put down here is that the genes that are defective in HHT are important for angiogenesis, which means the birth or the formation of blood vessels and vascular remodeling. What is angiogenesis? Well, angiogenesis means that from a primary avascular network, blood vessels are remodeled to either grow or to be pruned. And these mature vessels, they, over the course of the lifetime, are approximately every 7 years renewed, i.e., the vessels have to undergo a destabilization process. The unstable vessel can either grow or regress, depending whether or not there's a need for this vessel or whether there's no significant need for this vessel. The angiogenesis has 2 different compartments, the so-called activation compartment, where the blood vessel starts to be more plastic, i.e., the basement membrane, everything that stabilizes the vessel, is destabilized, is degraded, and new sprouts can form. This activation phase has now to be balanced, however, with a so-called resolution phase, where there's a stop of the cell proliferation, the basement membrane is reconstructed, the blood vessel again gets mature, and the endothelial junctions are formed. And what HHT is doing is that there is an imbalance between the activation phase and the resolution phase. The activation phase has to be switched off to go into the resolution phase, and this is what the gene products that are defective in HHT are mediating. And therefore, if you have a problem with these gene products, there will be an imbalance of activation versus resolution phase, and this can lead to structural abnormalities of vessels, i.e., abnormal arteriovenous connections. And these abnormal arteriovenous connections can either be direct connections, i.e., this is an artery, this is a vein, and we have a direct connection between an artery and the vein, or there can be nidus type. These are the telangiectasias that you may have on your lips or on the tongue. These are the brain AVMs that can be present, or the pulmonary or GI arteriovenous malformations. And there is an intervening network or glomus of abnormal vessels there. We've looked all the way back in 2005, when I was still in Paris, at the different neurovascular phenotypes of HHT and related them to the patient's age. And we found 4 different phenotypes. The 4 different phenotypes are depending on the patient's age. The spinal arteriovenous fistula, by far the rarest of them all, means that we have a spinal vascular malformation where an artery directly connects to a vein, and because the vein is not accustomed to have an arterialized pressure, the vein starts to enlarge. And this is just like a balloon growing, and the bigger this balloon is, the bigger this venous pouch is, the thinner the wall will be, and therefore the more likelihood of a bleeding that may occur. These were patients that were typically symptomatic very early on in their life, mainly because these fistulas are in all likelihood highly symptomatic and they can distort the cord. What we see in these patients are findings like here, where we have remodeling of the bone due to the large venous pouch. We see enlarged feeding arteries and draining veins. And the way that we treat these types of fistulas is that we go into the artery from the groin or from the radial artery. We enter into the transition between the artery and the vein, and we close off this abnormal communication from the inside of the vessel. And this can be done with, for example, glue, crazy glue, i.e. a substance that immediately hardens upon contact with, for example, blood can be used, or we can put in small platinum spirals, so-called coils, to close this off. The second manifestation that we identified were the so-called arteriovenous fistulae within the brain. And these are both infratentorial, i.e. in the back of the brain, or supratentorial. And what was very common in our experience was that you not only had one of those arteriovenous fistulae, but multiple. Arteriovenous fistula means that there's no intervening network, no nidus, in between the feeding artery and the draining vein. And again, these were more younger patients. The mean age was actually 3 years in these patients. And what we are seeing in these patients is these are the normal arteries in the brain. This is the normal size. And you can see that this artery here is significantly larger than its counterpart. This artery here is also significantly larger than its counterpart. And this enlargement is because there's such a high flow going from the artery into the vein, because there's no intervening normal brain tissue. And this high flow directs the flow away from the brain. You can see here that the majority of the contrast, the majority of the blood is going directly into this venous pouch. And this can now explain why the patients become symptomatic. They can become symptomatic due to three major reasons. Number one is the blood flow is no longer going to the brain. And this leads in young patients to a condition that is called melting brain syndrome, i.e. where the brain, simply because it doesn't get any longer nourishment, shrinks away and shrivels away. So it's a true arterial steal from the normal brain tissue. The second possibility how these patients can become symptomatic is due to bleeding, hemorrhage. And this is due to the fact that, again, similar to the spinal arteriovenous fistulas, the ballooning of the venous pouch will lead to a thin wall that can then at one point in time rupture. More difficult to explain is this concept of venous congestion. Here the problem is that the brain cannot drain normally because the outflow route that it tries to take, i.e. the venous drainage, is congested, is arterialized, and therefore the brain has problems of drainage. It's just like that if you want to drive on a congested highway, if there is too much, if there's a traffic jam, you cannot drive down this route simply because too many other cars are there. If there's too much blood flow in the veins, then the normal brain cannot drain normally. And these are a couple of examples here. A young patient who had this large arteriovenous fistula that we were able to treat. Here another example, direct communication between the artery and the vein. And the treatment in these patients will be highlighted in the next couple of slides. We see in this patient here with a large pouch that has bled, the bright portion is actually blood in the brain, that this patient not only had one fistula here, but a second one here and a third one right here, as we see an early draining vein here, here, and in this area here. And this is quite common in patients with HHT, that there's not only one arteriovenous malformation, but multiple ones. Here we see a patient where, again, there's the direct communication between the artery and the vein right here. So we go with our microcatheter all the way to the area where the shunting occurs, i.e. here. And then we can either drop coils, platinum spirals, or this so-called crazy glue or N-butyl cyanoacrylate into this artery to stop the blood flow going into the abnormal venous pouch. Here another example of a young child that I treated a couple of years ago, who had multiple fistulas demonstrated here. And this is our microcatheter injection. So we are going all the way from the groin into the small arteries in the brain, inject the glue. This is the glue cast. And this is the immediate result. There's still some shunting, but we waited for 2 months in this patient. And because the glue is thrombogenic, leads to thrombosis, this is the follow-up with the patient being completely cured. Here is another example, a 2.5-year-old girl who had these abnormal vessels here. And we saw the artery, the veins. We go through the groin all the way from the artery into the vein. And in this patient here, I put in platinum spirals, so-called coils, to close off one fistula and the second fistula. And then on follow-up, you could see that there was a third fistula here. And after this was treated too, we see here the follow-up with now normal arteries going to the normal brain and no longer any fistulization. This is another patient that I treated from Shanghai, who had, as a newborn, this large fistula. And we go into the area where we have the fistulization. You see that the normal brain is no longer getting any blood supply. So this patient would have presumably died within the next couple of days because the brain would have shriveled away. So we treat by just closing off the artery, and you see that immediately now the blood is redirected to the normal brain, and the child did actually very well. The third neurovascular malformation that we need to discuss are the AVMs, the arteriovenous malformations. They are more common superficial. They are present in elderly or in, not any longer like the pediatric age group, but still young adults. And we can see that these patients have a tangle of abnormal vessels in between the artery and the vein. So rather than having a direct fistulous component, you have abnormal vessels in between the artery and the vein, the so-called nidus. And here the treatment is a bit more complicated because you cannot just close off this artery here, but you have to take the entire nidus of abnormal blood vessels with you. So you have to push your liquid embolic agent, if you are performing an endovascular treatment, all the way from the artery into the vein. The other alternative for these types of treatments is surgery, where the surgeon, after opening the skull, puts a clip on the artery, a clip on the vein, and then excises the arteriovenous malformation. However, this depends on where the AVM is. If the AVM is located deep in the brain, then it may be difficult for the surgeon, the open surgeon, to find the AVM. And in these cases, an endovascular approach is a possibility. The third treatment option for these AVMs is that you perform radiosurgery, such as is called gamma knife. A couple of examples here. This is a patient where on routine screening, we found an abnormal tangle of vessels here and here, making the diagnosis of a brain AVM. Here you see the microcatheter injection. This is the feeding artery. This is the tangle of abnormal vessels, and this is the draining vein here. So here your liquid embolic agent has to go all the way from the artery through the network into the vein in order to completely treat this patient, or you perform surgery with a clip here, and excision, cutting out of this portion of abnormal vessels. And you can see very nicely that this corresponds to this nidus or glomus that we have seen in the model of brain HHT. This patient became symptomatic with a bleed. You can see the hemorrhage in the brain right here. And in these types of instances, we perform a contrast-enhanced study, and you can see that there's an abnormal tangle of vessels with a focal outpouching pointing into the bleeding cavity. And this focal outpouching was the source of this patient's bleed. In these cases, you can either perform surgery or you can go through the blood vessels. And this is what we opted for. You see my microcatheter, i.e. a very small tube that we can insert from the groin and that we can navigate all the way into these small brain vessels. These catheters are less than 1 millimeter in size, and they do go into these very distal, very small blood vessels. You can see here the microcatheter injection. This is the abnormal nidus. This is the draining vein. And you can see that the cast of, in this case here, glue went all the way through the abnormal vessels, through the area that had bled into the vein, thus sealing off the AVM. And this is before, this is after, and these are all now normal arteries, and the patient was cured from his AVM. Another example here, there's the bleeding cavity there, there's the outpouching right there. Right there is the outpouching, the tangle of abnormal vessels. We go with our microcatheter into this small blood vessel right here. We can inject the glue, and you can see here the glue cast, sealing off the point of hemorrhage, and the patient did very well and had no deficits. Sometimes the problem of those brain AVMs is that with time, the veins start to get smaller and starts to shrivel away. And then you have an increased inflow into the AVM, but a decreased outflow. And in these patients, we see very commonly bleedings to happen. So this is something that we like to look at in the follow-up, because we don't need to treat every single brain AVM. But in those where we see the formation of narrow rings within the vein, these are the ones that are at a higher risk of bleeding. And here you can see such an example. We see the feeding artery number 1 here, number 2 here. We see the abnormal tangle of vessels, the draining vein here, and then this draining vein has a massive narrowing and continues here with its normal size. And because of this massive narrowing, we now have the problem of congestion, i.e., there will be a traffic jam here, and the blood flow that is going through this area can no longer drain out. And these are the moments where an AVM can actually rupture. And you see here our microcatheter, and this is now the injection of glue in real time. You see the microcatheter right there. You see now the glue is coming out, going into the vein, sealing off the venous structure, and we are able to thus completely close the arteriovenous shunt. And this is the follow-up of the same patient. The abnormal tangle of vessels is gone, and all the normal arteries are still there, and the patient did very nicely. One way to treat AVMs is, as I've shown up to now, through the front door, i.e., you go through the artery and you close off the nidus from the arterial side. The alternative is to go through the back door, i.e., you go from the vein and inject retrogradally against the flow your liquid embolic agent. And this is one example where we couldn't use a front door approach because a normal artery was going off here. There's the tangle of vessels. So I went through the vein and closed off the AVM from the backdoor approach. So this would be a so-called transvenous approach in brain AVMs. The last vascular malformation that I would like to discuss are the capillary malformations. Capillary malformations do not shunt, and they never bleed. These happen to be also the types of vascular malformations that are the most common ones that we are seeing. And they are present in the even older population. So remember, the spinal and brain arteriovenous fistulas are in the youngest population. Then we have the AVMs, and then we have the capillary malformations. And in most instances, we are finding them completely incidental. And since they have very low or zero risk of hemorrhage, we would not treat them. In fact, sometimes they are really difficult to identify. So here you see maybe there's a little bit of like too many vessels here, or there's a fluff of abnormal vessels right there. And in the later phase, you can see the fluff of abnormal vessels here and here. Or in this case, you see a fluff of abnormal vessels here. But what you don't see is the draining vein, the early drainage of the vein. And therefore, there's no shunting going on in these types of vascular malformations. And because there is no shunting, we believe that these are vascular malformations that do not bleed. A couple of examples. They are readily picked up on MRI as a fluff of contrast enhancement. We can see them on DSA, but they are not associated with an abnormally or early draining vein. And because there is no shunt in them, they are not dangerous and we would not treat them. So a couple of like take-home messages. As I said, the spinal arteriovenous fistula, the cerebral arteriovenous fistula, they are the ones that are classically present in neonates and young children. There's AVMs, and the capillary malformations are present in more of the elderly age group. And this leads us to the question, do actually those fistulas vanish, or do they transform into an AVM? Or do they just become symptomatic earlier? And we believe that this is the case. Since they tend to hemorrhage more often, these are also the ones that we would always treat. The second interesting point for arteriovenous malformations is the multiplicity. We have here identified that the likelihood of having HHT and having multiple brain AVMs is quite high. Multiplicity in brain AVMs in the sporadic group here is very rare, i.e. Less than 1%. So we believe that if you have multiple brain AVMs, it's highly predictive of the diagnosis of HHT. The other interesting fact is that although you have the same mutations, there are different expressions. As I told you, some patients have no AVMs. Actually, the majority have no brain AVMs. Some have these very dangerous ones. Some have actually very, very simple or very not very safe vascular malformations, i.e. these capillary telangiectasias, and this despite the same mutation. So how come that some of the vascular manifestations look like this and some look like this? And we don't know this yet. And there's interesting research work going on that actually helps us to understand why these brain AVMs form. And this will help us to not only understand brain AVMs in HHT, but also in the sporadic age group, and could help to lead to, at one point in time, treatment options that are based on, for example, the injection of anti-angiogenic drugs such as Avastin in these patients. Final point that I want to make is, in general, in sporadic brain AVMs, we have a risk of bleeding of approximately 2 to 4% per year. In the larger series, the risk of HHT AVM patients to bleed is lower. However, this is, in our opinion, due to the fact that in these series, all vascular malformations that I just presented to you are lumped together. And since these capillary telangiectasia or capillary malformations are so common, presumably they lead to the fact that the overall risk of bleeding is low. So what is our approach in Toronto? We treat all of those direct fistulas. We do not treat the capillary malformations. And if we have a true brain AVM, we discuss with the patient, we offer all different options, radiosurgery, surgery, and embolization, or observation, and discuss and individualize the treatment approach. And with this, I would like to thank you very much for your attention.
Thank you very much, Dr. Krings, for a really amazing and informative presentation. To be honest, some of the images you showed were really very fascinating, so thank you again. We have a few minutes now for some questions from our audience members. So first of all, the first question is, in a family who has relatives with brain AVMs, how concerning is a finding of developmental venous abnormality with no other brain AVM findings on MRI? And then as a follow-up to that, what complications could that cause?
Okay, so we have seen that patients with HHT tend to have more common, the so-called developmental venous anomalies. These are completely benign anatomical variations. So DVA does not bleed. A DVA can be rarely associated with a cavernoma, but on average, we would never treat a patient with a developmental venous anomaly. They have been previously called venous angioma, but this is a misnomer. It is truly an anatomical variation without a risk for hemorrhage. So we see in our vascular malformation clinic at the Toronto Western Hospital quite a few patients who are concerned, doctor, I have like a venous angioma in my brain, and then they Google angioma and they see, oh, that's something that can bleed. No, it's truly an anatomical variation, and therefore there should be no risk.
Okay, wonderful, thank you. The next question we have is, can a brain AVM aneurysm happen again if it was coiled and treated years ago, or is it considered to be cured, so to speak?
That is an excellent question. In fact, this is one of our current research. We have one patient who, but it was a sporadic AVM, who was treated at an outside institution, follow-up MRI demonstrated, and angiography demonstrated that the AVM was completely gone. And a couple of years later, the patient presented to our hospital with a newly formed, interestingly enough, very close to the previous location AVM. And this opens quite a few questions. My personal take on it is, at the beginning of the talk, when we discussed about angiogenesis, I discussed that every 7 years or so, your blood vessels remodel. If you have a somatic mutation, or like a genetic or germline mutation, i.e. HHT, and you have the propensity to develop an AVM, then because your blood vessels in the brain turn over every 7 years, with each time they turn over, there's again the risk of an AVM to form. How often does this happen? Extremely rare. Extremely rare. But this is the reason why in our HHT practice, I like to follow up patients on a regular basis, approximately every 5 to 7 years, given the fact that there is a remodeling of the blood vessels going on, and therefore theoretically the possibility of an AVM to reform. Again, how often is this? Case reportable rare. I have seen in 13 years of practice in Toronto, 5 years of practice in Paris, and previous practice in Switzerland, I've seen one case.
I see. And then also as a follow-up to that question as well, for that brain AVM that was coiled and treated, do you think that stresses such as pregnancy and delivery could then cause it to burst?
This is a matter of contention. We do not recommend C-section for patients with a known brain AVM when they give birth, because the risk is not perceived to be significantly high. Or to put it in other words, I have yet to see a patient who during delivery had a burst AVM.
Okay, wonderful. And for the next question, how many gamma knife procedures would be treated for this condition in a year in Canada?
So we are performing approximately 50 gamma knife procedures per year for brain AVMs at the Toronto Western Hospital. I would, we are the largest volume center in Canada. I would say my guesstimate would be that within the entire country there will be